Hello, my name is Dr. Jonathan Ungar. I'm the Medical Director of Melanoma Clinical Services at the Waldman Melanoma Center at Mount Sinai, and I'm here with you today to raise melanoma awareness. Well, melanoma is a type of skin cancer that forms from cells called melanocytes. Normally, these cells produce pigment, which is actually protective for the skin. It's called melanin, and it protects the skin from ultraviolet damage and rays. Now, while the majority of melanomas actually form in the skin, they can actually form in other organs. And sometimes we find them in the eyes, in the mouth, in the genitals, and even in the anal area. There's an estimated 95,000 new melanomas that were diagnosed last year. Melanoma can affect people of any age. The average age of diagnosis is about 65, but it's also one of the most common cancers found in people under the age of 30. So age is really vary quite dramatically. Additionally, actually, over the last 10 years, the rate of melanoma diagnosis is increasing at about 1.5%. So it's still a problem, and it's still a growing problem. There are certain factors that predispose people, or certain risk factors for developing a melanoma. Those include a family history of melanoma, a prior melanoma in a person, fair skin, light hair, freckling, having many moles. And there are several others, but it's important really to remember that these are risk factors, and it does not mean that if you don't have these, that you can't develop a melanoma. One last thing I do want to mention about melanoma is that 20 to 30% of them arise from existing moles, but that means that most of them actually arise from normal appearing skin. You know, as is the case with many cancers, actually probably the most important thing is early detection, even before we discuss treatment. And I'll give you an example. So catching a melanoma at stage 0 or very early when it's confined to the outer layer of the skin, the 5-year survival rate, or the percent of people who are alive after 5 years, is 98%, which is incredible. After it has metastasized or spread to other organs, that number actually drops down to 20 to 25%. So early detection is so critical for most cancers, but especially melanoma. Now, once a diagnosis is made and then appropriate lab work is done, imaging tests have been done, there are a few elements that may play a role in a patient's treatment. Surgical removal of the melanoma is almost always a component of the treatment. It may be just a local, what we call wide excision. It may involve the removal of nearby lymph nodes. We call that a sentinel lymph node biopsy. And in more advanced cases of melanoma, chemotherapy may be used. Some exciting advances really have arisen in the last few years in the treatment of melanoma. And these are really much more targeted therapeutics than standard chemotherapy, which can affect cells all over the body. These targeted immune therapies are drugs that are more like guided missiles rather than sort of bombs that just hit an area and cause collateral damage. Some of these actually target genes that are mutated in melanoma cells, but not in normal cells. And so they're able to target the bad cells and leave the normal cells alone. In other cases, these therapies are targeted towards the patient's own immune system to modulate it and to change it in a way that allows the immune system to attack and destroy melanoma cells. So each patient and each case is a little different, but the combination of all of these things usually plays a role in the treatment of melanomas. So the Waldman Melanoma Center is actually a new and exciting center at Mount Sinai, bringing together clinical diagnosis, treatment, and research all under a single roof. So aside from being able to provide cutting-edge care, each of these elements sort of feeds one into the other, creating really exciting sort of opportunities for developing a better understanding of melanoma, which leads to better development of treatments in melanoma, which then leads to better outcomes for our patients. You know, one thing that I mentioned earlier is that early detection of melanoma is so critical for patients and their lives. And with the generous philanthropic grant of the Waldman family to create our center, we're able to bring some really exciting technologies all together under one roof, which will allow us to better track patients and also better diagnose melanomas. For instance, we're offering cutting-edge total body photography. In the past, and still today at many places, this was done by painstakingly taking photos of every part of the body, manually cataloging each lesion and mole, and then manually comparing photos over time. As you can imagine, it's a very time-intensive process. At our new center, we'll be providing total body photography, but using our machines and technologies that we have in our center rather. This is done by multiple cameras, over a dozen cameras taking photos simultaneously. So the photography takes literally seconds. Then the photos from all of these cameras get fed into a really sophisticated software that automatically creates a map of the entire body, catalogs all the moles and lesions, and creates this real map that can detect changes over time in the order of millimeters. So rather than being a painstaking process that few people really are able to do, this is something that we're going to be able to do for a lot of our patients and really quickly and easily manage them over time, and then allow the clinician to focus on the things that are changing and not on the, the 50 other moles that are completely normal and are completely static. In addition to the total body photography, we're also using other exciting technologies to determine whether a mole or a lesion is a very early melanoma, meaning that not tomorrow or the next week it's going to turn into a melanoma, but maybe 2, 3, 10 years down the road. Among these technologies that we're using is genetic sampling, which actually uses tape stripping. It's so easy. It's like putting a piece of tape on your skin and then peeling it off. And also sophisticated electrical impedance machines that measure changes in electrical impedance of the skin. And so using all of these things and the expertise of our clinicians, we're really going to be able to provide really, really early detection and know which moles, number one, are going to be changing into melanomas down the line, and certainly those that are at risk of it and need to be monitored really closely. If that wasn't enough, we also are integrating imaging modalities that will really help us to diagnose melanomas without any cutting. So, in most cases today, diagnosis of melanoma is done with a biopsy. And although that's a quick, easy procedure outpatient, it takes maybe a few minutes at most of the biopsies that we do turn out to not be melanomas, fortunately. But what it does mean is that with biopsies, we're producing unneeded wounds and scars. And so, you can imagine a patient who has a very high risk is over their lives going to have many concerning lesions and many biopsies, all of which will leave some scar or another. With these new cutting-edge, non-invasive diagnostic tools, we're actually able to make these determinations without any needles, without any blades, and ultimately without any scars. And so I think these are all examples of things that we're bringing together to bear to help with our patients in terms of detection, early detection, and hopefully minimizing the need for some of the even more sophisticated treatments because we catch them so early that we're able to deal with them very easily. So in general, regular screenings with a dermatologist are important. In people without a history of melanoma, we usually recommend an annual check. And we often recommend scheduling them in the month of your birthday so that you don't forget. Unfortunately, with COVID and its dramatic impacts on our lives, much of our preventive healthcare, including skin cancer screenings, are being delayed and pushed back. This is overall for everyone's safety, both patients and the providers. But in the coming weeks, months, as things start to open up and people are further able to come into the offices in a safe way, people who have missed skin exams certainly should be scheduling those to catch up. And I think for many of the people who have never had them before, it's a good time and a good reminder to do it now and get started with it. We often recommend that people do monthly self-checks, and I won't go into the details here. There are a lot of details on the internet regarding how to perform those. But the key is, you do it once a month just to look for any concerning features or changes. But it's really important to emphasize that this does not substitute for screenings with your dermatologist on a regular basis. But even in the time of COVID, if you have a mole that you're concerned about, you can use telehealth to discuss it with your dermatologist. They may not be able to easily check it, because often the resolution of cameras, although excellent these days, is not good enough. But if you send a photo or you can look at it with your provider, and they may be able to tell you, you know what, this is not as concerning, we can look at it in a few months, or they may tell you this is really, really concerning, and despite the risks related to COVID, the need for you to come in is really critical. So it definitely still plays a role, and people should be using it as much as they can. So the key thing I think is that it's important to stress is that people should not be diagnosing their own melanomas. It's not quite as simple as that, but we have a mnemonic that we often discuss, the A, B, C, D, E's of melanoma. And each of those represents a factor that, if it's abnormal, may increase the risk of a specific mole or lesion being a melanoma. So A of A, B, C, D, E stands for asymmetry. An ideal mole is a perfectly symmetrical, round, or oval shape. Now, just because it's asymmetric does not mean that it's abnormal, but we want ideally symmetric ones. So A, asymmetry is a risk factor or a sign of melanoma. B stands for border. We ideally want a smooth, regular border. Often melanomas have irregular borders, so a mole with an irregular border, another lesion with an irregular border, that may be a sign that this may be a melanoma, or maybe an irregular mole, or frankly, in some cases, it might be a regular mole. C is color. Ideally, a mole is a single color and uniformly colored. The more different colors and shades within a given lesion or mole, the more concern that there is that it may be abnormal. D is diameter. The larger the diameter, the higher the risk that the mole is abnormal. We usually think about the size of a pencil eraser, or 0.6 centimeters, 6 millimeters as a cutoff, but the general idea here is the larger the mole, the higher the potential risk. And the last one, E, is evolution. That is in some respects the most important, and if you can only remember one, that's probably the one to remember. Melanomas evolve. E stands for evolution. They change over time, and they usually change relatively quickly. So any changes that you're noticing in a mole or a lesion, particularly if it's happening on the order of weeks or a couple of months, is something you want to bring to the attention of your dermatologist. Not all things that are changing are abnormal, but if you see something that's changing, that's not the time to say, you know what, let me keep an eye on it myself. It's better to go see a dermatologist and have your dermatologist assess it and let you know whether it's something that needs to be evaluated. Again, all of this doesn't substitute for regular skin checks with your dermatologist, but these are things that you can do on your own in between those checks. I think the last thing that I would like to discuss is really prevention is important, screening is important, but the two together are probably the best combination that we have to combat melanoma. And so we've discussed screening, regular screening, how to screen at home, how to screen with your dermatologist. But in terms of prevention, it's really important. And the keys to that are sun avoidance and sun protection. So what is sun protection? It includes the daily use of sunscreen. We recommend SPF 30 or higher, and it should say broad spectrum on the label. You should remember, particularly with sunscreen, you're supposed to reapply it every 2 hours, or more frequently if you're getting into water or sweating a lot. There are sun protective hats, which are really important, particularly broad brimmed hats that can provide shade to your face and neck. And you know, baseball caps are okay, but they don't protect your ears, they don't protect your neck. So really something with a broad brim that goes all the way around is optimal. Sun protective sunglasses, if you recall, I mentioned that melanomas can arise in other tissues, including the eye, and so sunglasses can help protect from ultraviolet radiation. But even better than sun protection is sun avoidance and avoiding direct sunlight, particularly between 10 a.m. and 4 p.m. when the sun is the strongest. So staying indoors is ideal and is the best, but if you must be outdoors, and I'm not telling people that we all have to hide it indoors until the sun sets, but if you are going to be outside, you should really be making every effort to be in the shade. You will still get sun exposure, so all the sun protective behaviors like sunscreen and hats and sunglasses are still important, but by being in the shade, you'll be able to minimize your exposure even further.